Very good evening, everyone. On behalf of IAP India technical team, I, Dr. Jaspreet, welcome you all. I would like to welcome our today's speaker, Dr. K. Kamlesh Jain, sir. Welcome you, sir. And our today's moderators are Dr. Rini Chakrabarti and Dr. Shauli. We welcome you both on IAP India platform. And before over to Dr. Rini, I would request to all the participants, please like and subscribe IAP India YouTube channel and Facebook page. Thank you. Over to you, Dr. Rini, ma'am. Please moderate this session. Thank you.
Thank you, ma'am. Good evening, everyone. This is Rini Chakravarti. We welcome you all to this webinar series on behalf of IIP Tripura State Branch and Women's Cell. I am taking this opportunity today to introduce our resource person, Kamlesh Jain sir. Sir is a sports physiotherapist who has worked in cricket for over a decade. He completed his BPT from SRM College of Physiotherapy, Chennai, specialized in sports physiotherapy from UK. He has been involved with various cricket teams over the years, including Bengal Ranji team, East Zone team, India A and India Under-19 cricket team. He has been associated with Kolkata Knight Riders IPL team since 2012 season. He is a founder of Physis, which is a center of physio and sports injury sciences. He recently he was conferred with the significant contribution in sports physiotherapy awarded by IAP during the annual conference in Chennai in March 2020. Now I over to you, sir, to proceed with your presentation. Before that, I want to request all the participants to drop your questions or queries to the chat box. It will discuss by our resource person after his session. Over to you, sir.
Am I audible, Rini?
Yes, sir.
Yeah.
You're audible.
Thank you, Rini. Yeah, thank you, Rini, for that introduction. Once again, it's great to be on this IAP platform again, this time being invited by the Tripura branch of the Indian Association of Physiotherapy. So my topic of presentation tonight is on hamstring injuries in cricket. So hamstring injury, as we all know, is one of the most common soft tissue injuries that we see in cricket. We have other soft tissue injuries like rectum, side strains, calf injuries, but hamstring is the most common soft tissue injuries in cricket. It's got a prevalence of about 15% in cricket, which is quite high. And again, the issue is it's associated with a high recurrence rate. About 14 to 63% have a recurrence of a hamstring injury within 2 years of the initial episode. Although it's a high prevalence injury, there's a lot of research on hamstring injury. There's a plethora of literature available. There's still a lack of consensus on the effectiveness of various rehabilitation programs for this specific injury. Of this, this is an extremely challenging condition to treat, both in terms of assessing as well as managing. So my aim of presentation this evening is to give an orientation of the anatomy, risk factors, and the mechanism of injury for a hamstring injury. Then we will discuss about the importance of a detailed assessment. And then finally, we will move to the management and mitigating injury recurrences strategies. So if you look at the anatomy of the hamstring muscle, I'll just quickly get my pointer. Okay, that's fine. Good, no worries. So if you look at the anatomy of the hamstring muscle, as we all know, biceps femoris, semitendinosus, and semimembranosus. If you look at semimembranosus first, it arises from the superior part of the ischial tuberosity and goes and inserts into the medial condyle of the tibia. The semitendinosus and the biceps femoris, the long head, they have a conjoint tendon origin at the inferior part of the ischial tuberosity, the semimembranosus goes and inserts into the guy ropes, the pes anserine muscles, that is the sartorius, gracilis, and the semitendinosus. The long head of the biceps goes and into the head of fibula. From the linea aspera of the femur, the short head also joins the long head, and they go and insert into the head of the fibula. This is the anatomy we all know. But what we need to know is this. If you look at the anatomy if you look at the morphology of the biceps femoris muscle, every muscle has a tendon at its origin and its insertion. In the case of hamstring muscles, we have a central tendon which runs through the muscle. So this is the anatomy of the biceps femoris. You can see the proximal tendon, we can see the distal tendon, and then you can see again a central tendon running. So this is the proximal muscle tendon junction, and this is the distal muscle tendon junction. Why it's important for us to know is because of the fact that an injury to the muscle, an injury to the muscle tendon junction at this area, and then an injury to the central tendon can have different rehab programs, and it can have different prognosis. So it is extremely important for us to know where the injury happens. Similarly, if you look at the case of a semimembranosus muscle, it's got a long proximal origin and it's got a short distal tendon. Okay. Again, you can see the central tendon running through the entire course of the muscle. So when we have a semimembranosus injury, we need to know if the injury is in the muscle belly, if the injury is in the muscle tendon junction, or if the injury is in the tendon specifically. Now, if you look at the risk factors for a hamstring injury, age we all know it's a non-modifiable risk factor. So athletes above the age of 28, the older athletes are for an injury. Previous injury, again, as we all know, all the research showing is a major and a strong risk factor for a hamstring injury. If you have an episode of hamstring injury, there's a good chance that you can injure your hamstring muscle again. Then if you look at the modifiable factors, the strength, obviously, if there's a decrease in eccentric strength of the hamstring muscles, there's a good chance for sustaining a hamstring injury. If you look at the other factors, studies have shown that reduced ankle range of motion, reduced dorsiflexion range, reduced hip mobility, especially internal rotation of the hip, and also muscle morphology. A lot of studies are now showing that changes in muscle morphology can also lead to hamstring injuries, like athletes who have shorter tendon lengths, athletes who have a shorter fascicle length of the hamstring muscles. They are also prone for a hamstring injury. Right, like moving on to the mechanism of injury. As we all know, hamstring muscle is more prone to an injury during the final phase of the swing phase. As the knee extends, the hamstring contracts eccentrically. This is the most vulnerable time where the hamstring can injure, as it undergoes an eccentric contraction. What we need to understand is whether it's a contraction type of injury or a stretch type of injury. So as you can see in the slide, a type 1 is a contraction type of injury. This is accompanied with high speed running, which generally happens with hip extension and knee flexion. Whereas you take a type 2 type of a hamstring injury, it's a stretch type of a hamstring injury, which happens with hip flexion and knee extension. Okay, so a type 1 is a contraction type, and a type 2 is a stretch type of a hamstring injury. So in cricket, if you see a type 1 injury can happen when a batsman is trying to complete a quick single, or a fielder is trying to chase a ball and is running quickly. That is a type when you can get a contraction type of hamstring injury where the hip is in extension and the knee is in flexion. So 90% of the contraction type of hamstring injuries will occur in the biceps femoris muscle, mainly in the long head of the biceps femoris. Now again, as clinicians, we need to understand whether the injury is in the muscle or in the muscle tendon junction, or is it in the central tendon, as I had spoken earlier, because injuries to each of these areas will have different healing times, different prognosis, and will have implications on the rehab. If you look at a type 2, a stretch type of a hamstring injury, this can occur primarily when in the front leg during the delivery stride of a bowler. Okay, so this is a stretch type where the hip is in flexion and the knee is in extension. So 90% of the stretch type of hamstring injuries occur in the semimembranosus muscle. Okay, so again, as I said earlier, we need to know where exactly the injury is. So if you look at the assessment of hamstring injuries, I think the subjective examination is the most important part of a clinical examination. A lot of the times we don't give importance to the subjective examination. We just do it like a formality. It's like just picking. But I think as a clinician, we need to give a lot of importance to the subjective examination, and that forms the core of our assessment. Ideally, at the end of the subjective examination, we need to have a working diagnosis or a hypothesis based on which we can start thinking on treatment lines and rehab lines. So in an ideal scenario, before we touch the athlete, we need to know what could be the extent of injury, what could be the structures involved, and a lot of other information. So give a lot of importance to the subjective examination. Then we do the objective range of motion, muscle testing, palpation. Then we support it with radiological evidence, and then finally we come to a diagnosis, what exactly the injury could be. So if you look at the subjective examination, I think these are all the critical things that we need to know. The onset of injury. The first thing we want to know is the onset of injury. Was it an acute injury or was it a gradual onset? Acute injury, we know that it could be a localized hamstring injuries. If it is a gradual onset, that we could know that there could possibly be a proximal component involved, like the hip or the lumbar cervical spine. We need to know the type of injury, as just discussed, whether it's a contraction type of injury or a stretch type of injury. That is, again, extremely important for us to know, because that will have implications on the prognosis of the injury. We need to know if the athlete has had a previous injury, because we know for a fact that previous injury is the biggest risk factor for an injury. Other concomitant injuries, if the athlete has had an ACL reconstruction where the hamstring graft was taken, if the athlete has injured the other hamstring, if the athlete has had any other knee issues, hip issues, calf muscle issues, lumbar spine issues, was there a change in training preceding to the injury? Did the athlete sort of change his training program, or the athlete was in a deconditioned state? It is always good to know what was the training program like during the injury. VAS score at the time of injury. We know for a fact that if the VAS score is greater than 6 at the time of injury, then the athlete is going to take a long time for the injury to heal and return to sport. The other thing we need to know in the subjective examination is did the injury stop the athlete from playing, or was the athlete able to continue playing? If the athlete was able to continue playing and finish the game, then we know that it isn't a major injury. But if it's something which stops the athlete from playing, then we know that there's a major component involved. The ability to walk and jog pain-free within a specific time frame after the injury gives us a good idea about how much time it is going to take for the injury to heal. We will discuss this in the prognosis part. And it's also a good idea to know where the site of the pain is, where exactly. So that gives us an indication which muscle is involved. It can also give us an indication whether it's a muscle junction or the tendon. But still, we would need radiological evidence to sort of exactly know where the site of pain is. So if you look at the objective examination, we're checking for the range of motion. We'll be seeing pictures for all of these. Then we look at SLR, we look at active knee extension. We look at strength measurements. We can do an isometric testing with a double leg bridge, a single leg bridge. We can do a bridge and catch. Then we can use biofeedback. We can use dynamometer. We can use isokinetic machines as well. And then we can use a palpation skills. And then obviously we need to assess the back as well. So if you look at the range of motion, so all these pictures have been taken from the Aspetar hamstring protocol. So first thing we need to check is the lumbar flexion. Okay? So we ask the athlete to stand straight with the knees extended and ask them to bend forwards as far as they can, and let us know when exactly the pain starts. Now, we need to understand that if we are assessing an athlete in the acute stage with a hamstring injury, we need to give proper instruction. We need to tell them to be cautious and just sort of don't go into a jerky movement, because that can flare up the injury. So as soon as the athlete bent forwards with the knee straight, we need to sort of know when exactly the symptoms start and sort of what is the lumbar flexion range. You can either use an inch tape to measure the distance from the tip of the middle finger to the floor, or you can just sort of make like it's coming to the tibial tubercle, or it's coming to the he's able to bend up to the malleolus or stuff. So in this assessment, we need to make 2 points. One is probably the VAS score. Say he's got pain 3/10. when he's sort of bending till the mid leg level, and document that. Next, we look at passive SLR range. So the main component is the contralateral hip needs to be stabilized, and then we passively take the hip into flexion with the knee in complete extension. Again, look for symptoms, record the VAS score, and record the range of motion till what range the athlete is able to sort of able to take the pain. Then we look at passive knee extension. Again, 90-90 position, 90 degrees of hip and 90 degrees of knee flexion, and with the other hip stabilized, you slowly extend the knee. Again, look for symptoms, ask how much discomfort the athlete has got recorded, and then here the inclinometer is used. We record what degree of knee extension the athlete has got. So these are all baseline measurements we are taking. So we can obviously keep repeating these measurements at regular intervals and see how the athlete is progressing. So if the athlete is able to do a complete knee extension in the active knee extension test, do something called as the MHFAKE, which is maximal hip flexion active knee extension. So we ask the athlete to maximally flex the hip while we stabilize the contralateral hip, and then we take the knee into extension. Okay? Now we need to be extremely careful if we are doing this assessment in the acute stage, particularly of high hamstring strains, the stretch type of injuries, because it can easily provoke the symptoms. So again, in this test, we need to record the symptoms, a VAS score, and then we need to record the range as well. Askling's hedge test. So here you can see in this diagram a knee extension brace just to keep the knee in complete extension. The examiner stabilizes the opposite hip. We can use belts as well to stabilize the spine and the opposite hip. And then we ask the athlete to do an active SLR, straight leg raise, check the range, and then ask the athlete to dynamically raise the hip, bring it down, raise the hip, bring it down. The key is the athlete should not have any apprehension as the athlete moves through that range, and should not have any symptoms. So next we come on to the strength component. We ask the athlete to do a double leg squat. Again, we check for the range and symptoms. If the athlete is able to do a double leg squat, ask them to do a single leg squat, first on the non-affected side and then on the affected side. Then we can ask the athlete to do a bridging protocol, starting with double leg bridging, then doing single leg bridging, and then doing a bridge and a catch. Now this can be quite challenging in the initial phase, so we need to be extremely careful about on the progressions. If the athlete has got a pain with the double leg bridging, I don't think so we should progress to a single leg bridging or a bridge and a catch. So these are all basically progressions and should be used sensibly. For the strength testing, I think it's a good idea to have a dynamometer, because it gives us some objectivity rather than just telling the hamstring is weak, the hamstring is strong. I think if we use a dynamometer, it gives us a number. It's good for us as well and for the athlete, because we can show the athlete on how they're progressing in the rehab. So this the hamstring can be checked at various angles: outer range, middle range, inner range. Okay, we can compare it with the uninjured side. And then we can also obviously check the quadriceps and the hamstring ratio. Okay, so we can check the hamstring strength in both the sides. We can compare it with the uninjured side and give an idea to the athlete on how much percentage the injured hamstring is weak. The other thing we can do is we can check for the quadriceps strength also, and it gives us a good idea on the quadriceps hamstring ratio as well. So so last 4-5 years we have the Nordboard in place. I think it's a fantastic equipment to check for the eccentric hamstring strength. So this is the Nordboard equipment. It is connected via Bluetooth or Wi-Fi to any of the smartphone or a laptop or iPad device. The starting position of the athlete, the ankles are stabilized, and then the athlete does a Nordic hamstring curl. So as the athlete does a Nordic hamstring curl, the readings are recorded on this, and then we get a reading. So this is how the report of a Nordic hamstring curl on a Nordboard looks like. So the blue ones here is the left hamstring, and the orange one here is the right hamstring. Right now we do a total of 3 measurements. So this is the average of the 3. The left is 412 Newton, the right is 429 Newton. So the difference is about 4%. And this is the maximal reading. So this is the best of the 3 readings. The left is about 430 and the right is 468. So we clearly know from this that the right is slightly stronger than the left. So we can keep doing this at regular intervals, and it's a very easy assessment to do, and it's quite quick as well. So when you're rehabilitating hamstring injuries, this is a great tool to have because it gives us a lot of objectivity and primarily checks the eccentric strength of the hamstring. Again, we can use isokinetic testing as well, but then again, these equipments are quite expensive and they're not ideal for working in teams. If you're working in one place in a specialist academy, then yes, this is great. But if you're working in teams, then this might not be an ideal scenario to be in. Palpation, again, extremely important. So when we are palpating, we actually do it on both the sides together. And then as the athlete starts to feel the tenderness, we record two things. One is the length of the tenderness and the distance of the proximal tenderness to the ischial tuberosity. Okay, so look at the length and the distance from the ischial tuberosity. So this is as far as palpation is concerned. So now we need to differentiate an acute hamstring strain along with a lumbar referred one. So if you look at the onset, obviously an acute will be sudden and lumbar would be gradual. Sometimes it can be sudden as well. If you look at pain levels, in the case of an acute hamstring, it will be moderate to severe. Athlete will find difficulty in running. There will be weakness and there'll be a markedly reduced stretch. Whereas in the case of a lumbar referred lumbar referred hamstring injuries, the athlete generally is able to walk pain-free. There'll be minimal reduction in stretch pain. Strength is almost maximal strength. Now, the slump is extremely critical for us to differentiate whether it's a lumbar referred or is it a localized hamstring injury. Slump is positive in the case of lumbar referred, whereas it's negative in the case of an acute hamstring injury. We will see hematoma in the case of an acute injury, mostly. In the case of a lumbar referred, there will be no hematoma. So I think clinically it is important for us to differentiate whether it is an acute hamstring or a lumbar referred one. And here is why I feel the subjective examination is extremely important. If you look at radiology, as we all know, there are three grades of the hamstring injuries. Grade 1 is where there's just a strain where stretch of the few fibers with no fiber disruption. In the case of a grade 2, there can be fiber disruption of a few of the fibers in the hamstring muscle. And the grade 3, there's a complete tear of the fibers. So we generally get a report from the radiologist stating that there is a grade 2 strain of the biceps femoris or a grade 1 strain of they say semitendinosis. But there's a lot of information that we need to know from the radiologist. If we can get a musculoskeletal radiologist to report on our injuries, I think that can be great because they give us a lot of information on the injury, which will then have implications on our treatment and our rehab and our return to play criteria. So as discussed in the first slide, other than knowing the grades of the injury and which muscle is involved, we also need to know whether it's a myofascial injury, whether it's a muscle tendon injury, or it's a intratendon, the central tendon injuries. Because as we discussed in the first few slides, the hamstring has got a central tendon, and any injury to the central tendon will take a longer time to heal than a muscle tendon injury, and a muscle tendon injury will take a longer to heal than a myofascial injury in an ideal scenario. So we need to know which part of the hamstring is exactly injured for us to plan our prognosis. So what is the information we need to know from the radiology reports? Which muscle is involved? Whether it's a myofascial injury, whether it's a muscle tendon injury, or whether it's a central tendon injury. The extent of injury, what is the length of injury? And if you can just try and correlate that with the palpation length that we take. What is the grade of injury? And how much fluid collection is there? Fluid collection is again a vague sort of measurement to have because everyone bleeds differently. The other thing we need to know is the distance of the injury from the bony attachment. The closer the injury to the ischial tuberosity, the more time it takes to heal. If there's an involvement of the central tendon, as already discussed. Sometimes, if you're suspecting any proximal or any distal involvement, then it's a good idea to get the back or the hip or the knee or the ankle also examined. So differential diagnosis for the posterior thigh pain, common as we discussed is a hamstring strain and referred from the lumbar spine. Less common in the younger population, we can have avulsion injuries. In the older population, we can have high hamstring tendinopathy. We can have nerve entrapments. We can have ischiogluteal bursitis, which is extremely difficult to differentiate from a tendinopathy. Clinically, we can have compartmental syndromes as well. And in some rare cases, we can have bone tumors. Sometimes a neck or femur fracture can sort of give a hamstring pain. So that is something we need to know. You can have sometimes vascular origin pains as well. So how do we manage a hamstring injury? In the early part, we generally follow the RICE protocol. So the RICE is now slowly moving on to POLIS, where it means protection. OL is for optimal loading, then ICE, compression, and elevation. We avoid all the obviously not pushing into pain. We need to respect the fact that there's a biological process happening, so that we are doing the pain-free ROM, strength proprioception. Then the intermediate stage, we progress and we progress our range of motion, and we progress our proprioception work. And once we are happy with the strength of the athlete, then we can commence base plyometrics and jogging. In the late stage, then we progress the field drills. We include a lot of running drills, side to side, agility, twisting, and turning, and then we commence high speed running. And then we build up good training workloads before we sort of give the clearance for the athlete to start going and playing games. So what are the treatment options we have when we're dealing with a hamstring injury? There are a lot of options we have: manual therapy, strength, neurodynamics, field drills, high-speed running, taping, soft tissue techniques, medications, lengthening and stretching. So a lot of tools we have with the hamstring injury. But the critical thing that we need to understand is the two main factors of when we are rehabilitating a hamstring injury is one is strength, and the other is high-speed running. These all treatments can complement these two, but we need to understand the fact that the strength, what we do in the rehab, what we do in the gym, and how much high-speed running we do is going to be critical, rather than just doing passive treatments on the table. Yes, there is a place for passive treatments, but we need to understand that if you're looking to get a really strong and a resilient athlete, then we need to give a lot of focus on strength and high speed running. So again, as I'm trying to reiterate the same thing here. Yes, manual therapy, massage, taping techniques, IISTM, all have this. But the key thing we need to understand is we need to give a lot of importance to strength work, eccentric strength work, a lot of high speed running, because you'll never have an athlete straining a hamstring walking or jogging. They all do it with high speed running or high stretching hamstring injuries. So we need to make sure that the athlete does enough eccentric work, enough high speed running in their rehab, and then build up good workloads at that intensity, so that one, we can get the athlete on the field as soon as possible, and two, we can prevent the relapse of the injury. So early to intermediate stage, we need to understand that there's a healing process happening based on the grade of injury, based on if the injury is in the tendon or the muscle or muscle tendon junction. We need to plan our rehab accordingly. Isometric exercises are great in the initial phase. There's been a lot of debate on concentric and eccentric type of exercises. So Carl Askling has done a lot of research on hamstring. He did a randomized control a trial where one group did concentric exercises and the other group did eccentric program. And what he found out was two things. One, the group that did eccentric exercises recovered in about 28 days, a mean of 28 days, whereas the group that did concentric recovered in about 51 days. So that's a good 14-day difference, which is significant in sports. So and the other thing he found out was the group that did eccentric exercises had a reduced relapse rate. So that is again interesting to know. And then we need to concentrate on the other components of fitness. Obviously, they can build up upper body strength, they can work on core stability and other areas where they were not good at before the injury. So as I was talking about the eccentric program, this is the Askling's eccentric program. Sorry, I just mute this. Okay. So he basically emphasizes on three exercises. One is the first one is so this is the Askling L protocol. So the first one is the extender. Okay, so the athlete lies down supine with the thigh stabilized with the hand, as you can see in the video. the athlete extends the knee and then bends it again. So you don't push the extension into full range. You try and respect pain as well. The second exercise is the diver, as if we are sort of trying to dive into a swimming pool. So here we need to understand the left leg is the affected leg. Okay, it's about 10 to 20 degrees of flexion, available on YouTube. And the third exercise is the glide. Just the diver is done alternate days, and the glider. So the left one is the affected leg, and this is done once in 3 days. Okay, so the other thing we need to understand is that the athlete might not be able to run on the ground. So we need to inculcate a lot of pool running whenever you feel it is appropriate. The other option is Alter G. So this is quite an expensive equipment, but it's a fantastic equipment. Get into the machine, and then you sort of zip the machine. As soon as you get into the machine, the machine calibrates your body weight, and then what you can do is you can manipulate with the body weight by altering the effect of gravity. That's why it's called Alter G, where we alter the effect of gravity. Say, for example, your athlete is 100 kgs, and you don't want the athlete to load and run at 100 kgs. You can just give the instructions to the machine, where you say, okay, I want to load only at 50% of the body weight. So your 100 kg athlete will be actually be running only with 50 kgs of body weight. Okay, so it's a great tool to have, very expensive, but if you get an opportunity to use this, I think it'll be really good. You can do a lot of work on running mechanics as well, because the body weight is less. So yeah, sorry, the next slide. Sorry, 1 second. Yeah, so what we'll do is I'll just put in a video. So this study was done by Mendiguchi in 2017, where they've done a lot of rehab exercises. This paper is available online. It's a great paper. We'll just through the video of this. A lot of exercises have been given. So in the regeneration phase, yes, we can mobilize the lumbar spine. We can do a soft tissue work through the hamstrings, through the calf muscle, through the plantar fascia. We can use electrical stimulation as well. We can do neural mobility. Yeah. So I'll just run through the video. So we can do your sliders and glide, hip extension, mobility work. Some hip thrusting, prone hip extensions. So a lot of exercises are given in this video, depending on what the injury. Again, hip thrusting, action with the loop band. Then we get into hamstring specific work, manual. You can do isometric work. Again, you can do single leg bridges and some ankle work. Get into some functional training work. Looking at lumbopelvic rhythm, side planks, bird dogs, dead bugs, and then slowly getting into running technique. You can see the key is sort of getting the triple extension in the back leg, encouraging hip extension as well. The key is to try and get the athlete running as early as possible. Progress the things. Again, we do a maintenance work, the PNF techniques here, full relax, where you're working on reflection. Again, single leg bridging with the medicine ball throws here, challenging for the athlete now. Trying and is doing some sled work now, trying and encouraging action again. Now trying to make it a bit more functional here. As you can see, you get the slider boards in place. We're doing the Nordics here, getting them lunging. Single leg deadlifts with a step up. We can do some concentric work as well. Hopping, single leg hopping, getting some plyometric work going, and then preparing for high running. Again, emphasis on core stability as well. As you can see here, things are a lot more functional here. strength and conditioning trainers. Fine. Now we get into training mode. A lot of emphasis is given on hip flexion, so we need to do a lot of A skips, B skips before we get them into high speed running. Okay, right. So the rehab graph. So when we are doing a rehab of any injury for that matter, this is what the athlete thinks. He's got injured. This is the time on the x-axis. This is the recovery on the y-axis. The athlete thinks he's going to get better every day, but unfortunately that doesn't happen in rehab. Every day is going to be different. There are days when the athlete feels great. There are days when the athlete doesn't feel so great. So we need to educate the athletes on the fact that you will have good and bad days during rehab, and that is part and parcel of the journey. So yes, so now we have assessed the athlete, we have diagnosed the injury, we have rehab the athlete, and we are now in a position to declare the athlete fit to return to play. So what is return to play? For a player, he wants to return to play in the shortest possible time. They want the player to return and sort of perform at pre-injury level. And for a physio, they want the player to return in the shortest possible time at the pre-injury level, and again prevent a relapse of the injury. So it's goal focus for a player, it's performance focus for a coach, and it's outcome focus for a physio. So when we take into account the return to play decision making, all these factors need to be taken into consideration, right? So first, is the athlete pain free? Ideally, we don't want to have any tenderness. How is the range of motion? As we did during our assessment, we need to look for the active knee extension, the SLR, the Askling test. As the athlete completed his rehab program, has he done enough strength work in the gym? Has he done enough functional training work? Has the athlete been subject to enough field drills, enough high speed running sessions? So this is all physio related. This is all we'll have to coordinate with the SNC work. This is where the coaching staff also come into play, because they are the one who are dealing with this. So we need to discuss with the coaches as well if they're happy with the skill workload that the athlete has done in terms of numbers bowled in the number of overs bowled in the nets, before we give them the clearance for match fitness. So all these factors need to be taken into consideration before we give the green signal for the athlete to sort of declare the match fit. So injury recurrence, yes, injury recurrences can happen. So what could be the primary reason? It could be early return. We probably underestimated the injury severity. It was not properly defined injury. Probably the injury was in the central tendon. We thought it was in the muscle belly, and we declared them fit early. Inadequate rehab. They didn't do the rehab properly. They didn't do enough work in the strength work in the gym, or they work properly. Be pressure from the player who wants to go and play out as early as possible. Then be a big game. They don't want to miss out on an opportunity. There might be pressure from the coach, the officials, the family. So these are all reasons where an injury can relapse. Okay, so we'll just quickly discuss what happens when a hamstring injury happens on field. Okay, so the first thing we need to understand when any injury happens on field is the safety of the athlete. If you feel the injury is going to cause permanent damage, then we need to get the athlete off the field immediately. Once you feel the injury is permanent damage, then we look and you feel the injury is manageable, then you need to look at the game importance, whether it's a league game or it's a final, or what's the role of the player in the team. And then we need to look at possible repercussions. What happens if the injury aggravates? What happens if there's any permanent damage to the athlete? So an example is this is a Bengal West Mumbai Vijay Hazare Trophy final when our captain got injured. So when he was trying to take a quick single. So this injury happened in the final. He felt a pop sound while he was taking a quick single, and a significant lip was seen. So when I went in, he said that he felt a pop sound, but he wanted to continue playing since it was a final of a major tournament, and he was aware of the possible repercussions. He knew that if 2 months off of cricket after this. So we need to do a quick subjective examination. Then we do an objective examination. Obviously, on field, we have very limited time, so we need to quickly do it. So quickly check the strength, isometric testing, check the range, and then check the palpation. So based on the limited assessment that I could do at that point in time, I felt it was probably a muscle tendon injury to the biceps femoris muscle. grade 2 probably because he felt a pop and he had a significant limp. So what treatment? So we offloaded his biceps femoris, and we sort of did a taping to restrict his end range knee extension, so that limits the stretch on his hamstring. So this is how this injury was managed on field. Now, if you reflect that case, we obviously know this is not going to cause permanent damage. This was obviously a big game. It was a big player who was involved, where he could contribute to the team's cause. And we were aware of the possible repercussions. If that injury aggravates, we knew that we have a good 8 weeks time after that game, just in case that injury aggravates. So what if the same injury happens, but it's a different scenario? What if it's the first game of the season? I think if it's the first game of the season, then we need to be careful, because if the injury aggravates, then the player is going to for the entire season potentially. So in that sort of a scenario, we need to get the player out, assess them thoroughly, rehab them, and then get them onto the field. Final of a tournament, but the player is an all-rounder who is required to bowl in the second innings. So as a situation where we are batting first, the player is an all-rounder. He's a bowler who bats, and then he's injured his hamstring while batting. So we would probably get the player off the field, strap him, so that he's able to bowl in the second innings. We don't want a situation where aggravates while running between the wickets, and then he's not to bowl in the second innings. He's unable to run quick singles as per the team's requirement. So if the team is chasing a stiff target, and the team's requirement is that they want the player to run quick singles, but he's not able to run, then it's obviously a good idea to get the athlete off the field and then take that decision. So we need to understand that the same injury can happen. The scenarios might be different. So it's not about just about as a sports physio. We need to understand the team's interest as well. You need to put the game context also into your decision making, and all the decisions are taken in consultation with the captain and the coach. So finally, we look into the prognosis of the hamstring injury. So older athletes will take longer time than younger athletes to recover. As discussed, if the VAS score is greater than 6/10 during the time of injury, then it's going to be more than 40 days. If the athlete has to stop from activity within 5 minutes of the injury, then they're going to take a lot of time to recover. In the case of MRI negative hamstring injuries, where there's no localized injury to the hamstring that is associated with an early return to play, more proximal to the site, more time for return to play. That's what I said. If the injury is closer to the ischial tuberosity, they'll require more time for return to play. Central tendon injuries significantly require more time for return compared to myofascial or muscle tendon injuries. Longer length of tenderness, more time for return to play. As during our assessments, we check for the length of the tenderness. If it's longer length of tenderness, then obviously it's going to take more time for return to play. If the athlete is not while walking, if the athlete is not pain-free within 24 hours, then there's a good 4 times more likely for him to require or her to require greater than 3 weeks for return to play. So the ability to walk pain-free within 24 hours after the injury is a good prognostic tool for us. Recent history, return to play. So as I said earlier, the recurrence and the relapse rate for a hamstring injury is extremely high, and we need to be very careful with that. Number of days required to jog pain-free. If the athlete is able to jog within 1 or 2 days pain-free, then they'll be fine in about less than 2 weeks. If they take 3 to 5 days to jog pain-free, then good chance that they will need more than 2 weeks. If they take more than 5 days to jog pain-free, then they'll obviously need greater than 4 weeks to return to play. So as I discussed in the first slide, the contraction type injuries and the stretch type of injuries. Okay, so the contraction type of injuries, the ones which happen in the biceps femoris, they'll actually be worse initially, but they actually recover pretty well. If you look at the stretch type of injuries, which generally happens to the proximal tendon of the semimembranosus, they don't look that bad initially, but they actually take quite a long time to recover. So the take-home message is a proper diagnosis of the hamstring injury is the key. We need to put a lot of emphasis on the subjective examination. This helps us in optimal management and mitigating injury recurrences. We need to focus a lot on strength and high-speed running workloads. The other components of treatment can complement. Now, this is a lethal combination. If you have an older athlete with the previous history of a hamstring injury and a reduced eccentric strength, this athlete is going to be extremely prone for a hamstring injury. We need to remember it's all in the rehab. We might be doing all the other passive treatments, but we need to make sure that the athlete does a good, strong rehab. So the take-home message is the best treatment for a hamstring injury is to prevent it from occurring. Yeah. So thank you. That's the end of my presentation. Happy to discuss any questions from the audience side.
Hello, sir. It's a very nice presentation.
Thank you, Rani.
We have few questions in chat box.
Yeah, I think 1 second. Do you want me to go open the chat box, Rani?
No, I'll read out the questions.
Yeah, perfect. Sure, that's fine. Perfect.
First question is difference between SLR and Askling test.
Okay, 1 second. So difference between SLR and Askling, is it?
Yeah.
Yeah. Okay. So the SLR is a straight leg test done, which is passive in the sense that the examiner actually takes the hip with the knee in complete extension. Now this is a slow test, if I have to say a better term. So we do we gradually sort of flex the hip into flexion with the knee extended, and then we look for any symptoms which the athlete has at rate get pain. Generally, that is done in the acute and the subacute stage of assessment of the injury. If you look at the Askling's H test, it's again a form of the SLR, but it's an active SLR. Okay. And it's a dynamic form of the SLR, okay, in the sense that the athlete takes the hip into flexion aggressively, sort of taking the hip into flexion and bringing it down, hip into flexion and bringing it down. So this is more an Askling's H test is more of a criteria for us to judge if the athlete is ready for the running phase of rehab. Generally, we will not do an Askling's H test in the acute stage of an injury because it can easily provoke the symptoms and aggravate the injury. So an SLR is a good tool to do in the acute stage of injury, where an Askling's H test, which is a more aggressive and a more dynamic form of the SLR, which is active as well, and that's a good tool for us to have in the and probably the subacute, the end of the subacute phase, where the athlete is sort of ready for high speed running.
Okay, so second question is, how do we differentiate between stretch and contraction injury?
Yeah, so the differential diagnosis again is in the history. So when we take the subjective history, the athlete will tell us when I was running to chase the ball, I felt a twitch in my hamstring. When I was running for that quick single, I felt a pop sound in my hamstring. So if that is the history which the athlete gives, then we know that it's a contraction type of injury which has happened with hip extension and knee flexion. Okay. If the athlete gives us an history key when I was bowling, and as I was completing my delivery stride and pushing towards the follow through, I felt a stretch pain in the hamstring of my landing leg, and I couldn't walk after that. That is an indication that it's a stretch type of an injury where it occurs with hip flexion and knee extension. So that's why I think we keep emphasizing on the fact that the subjective examination is extremely important for us to know whether it's what type of injury is and what structures might probably be involved.
Okay, so next question is, how can we check quads and hams ratio?
Okay, so you need to first look into the with the dynamometer or the Isokinetic, the Biodex machines, which if you have an access to, we need to check for the absolute strength of the hamstring. So in prone lying resisted knee flexion, then you can put them in high sitting and check for the isometric or the resisted testing for knee extension. Gives us the quadriceps strength. So we divide and then we look at the ratios. We all know that the quadriceps are obviously stronger than the hamstring. So in an ideal scenario, we want the strength of the hamstring to be around or greater than 75% of the quadriceps. Okay. So if the strength of the hamstring is less than 70 to 75% of the strength of the quadriceps, then we know that for a fact that the hamstring is weak and might be prone for injury. So we want the ratios for the hamstrings to be around 70% to 75% of the strength of the quadriceps.
Okay. Next is, Can we use CPM in this?
Yeah, you can use CPM, but CPM is the continuous passive movement is more used post surgeries. Yes, if it's a grade 3 injury of say the semitendinosus distal tendon, where there's a retraction of the tendon, and the athlete has been subjected for surgery. Post surgery, yes, we can use CPM. I don't see a major role for a continuous passive movement in the conservative management of hamstring injury. Yes, it's an option, but uh, probably I would use it post surgery of an ACL or a high grade hamstring injury. Definitely, I would use more active forms of treatment than a continuous passive movement for a hamstring rehab.
Yes.
Yeah.
My next question is, what is the reason behind having hamstring pain?
So as we discussed, it could be a lot of reasons. It could be age related. In younger population, it could be an avulsion injury. I mean, it can be a lot of reasons. Your hip mobility referred from the lumbar spine, reduced ankle range of motion. So all these factors could lead to a hamstring injury. Generally, it's not one specific factor. It's generally a multifactorial. So as physios, we just need to we shouldn't just be assessing the hamstring alone. We should be all the factors which can contribute to that injury and try and address each component in the best possible way.
Okay. What is slums? Sir,
Sorry,
what is slum? Slum. What is slum test?
slump test. Okay, so the slump
Yeah.
test is used to check uh, the neural tissue involvement of the lumbar spine. So the athlete in high sitting with both the knees together, we sort of the athlete puts the hand behind the back and just a lot of slumps his upper back, and then we take the neck into flexion. So with each step, we are getting a feedback from the athlete on what they are feeling, if they're feeling pain in the back, or if they're feeling pain in the gluteal region, or in the hamstring region, or in the calf region. And then we passively extend the knee and take it into dorsiflexion. So if it is a referred pain from the lumbar spine, the athlete will have a provocative maneuvers like the knee extension and the ankle dorsiflexion. They'll complain of a sharp shooting pain along the posterior thigh area, and as we take the neck into extension, the athlete says that the pain has completely resolved. Okay, so if the pain has completely resolved with neck extension, it is an indication that it is a lumbar referred pain. If the pain remains the same with the neck extension, then it could be a localized hamstring involvement. So it's a good test for us to isolate if it's a localized hamstring pain or it's referring from the lumbar spine. But as I said, the history taking is the key. If we take a thorough subjective history, I think without even touching the athlete, we'll be in a position to know whether it's a localized hamstring or is it or if it's got a proximal involvement.
Okay, so our next question is duration of rehabilitation program for hamstring injury.
So the duration depends on a lot of factors. I know we sort of have these generic timelines. A grade 1 can take from 2 to 3 weeks. A grade 2 can take from 4 to 6 weeks. A grade 3 can take around 6 to 8 weeks. But when it comes to the hamstring, a lot of factors need to be taken into account. Say, for example, a grade 1 central tendon injury to the biceps femoris can even take 4 to 6 weeks. So that's what I was sort of emphasizing in the presentation. When it comes to hamstring, you need to know where exactly the injury is, whether it's a central tendon or it's in the muscle belly or it's a muscle tendon junction, and only based on that we can sort of come into conclusions on what possibly could be a return to play timelines. Now, again, as I said, the stretch type of injuries and the contraction type of injuries, they also have a role to play in the return to play timelines. So all these factors need to be taken into consideration. Yes, generically you can say a grade 1 2 to 3 weeks, grade 2 4 to 6 weeks, but I think if you're looking for a holistic timeline, then look into all these factors before sort of giving the management and the coaching staff what could probably be a good return to play timeline for that player involved.
Okay. What is the difference between rehab phase for semitendinosus or biceps or semimembranosus?
Okay, so generally in a So the rehab would vary whether we are dealing with a muscle belly injury, or it's a muscle tendon junction, or is it a central tendon. So if it's a muscle belly, if we are sure with our clinical examination and with the radiological findings, we can be pretty aggressive with our rehab, because we know for a fact that muscles have good blood supply, and their healing occurs through a process of satellite cells, where within day 7, the new myofibrils sort of emerge from the scar tissue, and by day 21, the new fibril, the regenerative are formed. So whereas if you're dealing with a tendon injury, we know that tendons for a fact are devoid of blood supply, and their healing process is a different phenomena, in the sense that the healing occurs from an inflammatory pattern, where the extracellular matrix is forming, and then the collagen takes for about 6 weeks to took 6 weeks to form and get its strength. Also, in the case of a tendon, the tendon sort of functions like a spring, where it takes the load from the muscle and sort of transmits into the bone. So when the function of a tendon is like a spring, so it has to sort of generate that force, absorb that force, and then transfer that force. So it is not just about the muscle which we are rehabbing. It's important to know whether it's the muscle belly or it's a tendon which we are rehabbing, and based on that, our timelines would vary. If it's a belly, if it's a pure muscle belly, I'm pretty sure that will heal a lot quicker than an injury to the tendon.
Okay.
Yeah.
What to do to reduce pain?
Initially, I think you can just use the rest ice compression elevation protocol. First 48 hours, just ice it up as much as you can. Avoid all aggravating activities. Good to get a compression to the muscle as soon as possible. A lot of research now showing that the earlier you load the athlete, the better. But I think we need to be careful with the fact that there's a healing process in place. Get them into the pool as early as possible. In the case of severe injuries, where you have avulsion injuries, then I think we need to use crutches and put the athlete on non-weight bearing. If you're suspecting a grade 3 injury, the problem, if you start sort of loading early, is the retraction can increase, and then that can cause a long-term complication. So depending on the injury, depending on the grade of the injury, we need to sort of plan our early rehab. It is not a recipe, it's just guidelines we can give, and based on our assessment and the radiological findings, we need to plan that initial rehab accordingly.
Okay. What we'll do to prevent re-injury of hamstring?
Sorry, Rini, I didn't get that.
What we will do to prevent re-injury of hamstring?
Okay, so re-injury rates, I mean, as I discussed, I mean, if you have a hamstring injury, there's a good 5 times chance that you can re-injure it within the first 3 weeks of your return to play. So the things that we need to take care as physios is maintenance of range of motion. Make sure that they have a good thoracic spine mobility, good hip mobility, good ankle mobility. Make sure that their slump is clear. But the most critical is making sure that their strength is we are always on top of their strength. Once we do a pre-participation screening at the start of the season, so baseline measure on what their hamstring strength is, eccentric strength is, and once we give the return to play clearance, we want to make sure that at any point in time, their preseason strength measurement, what we have attained during preseason, is sort of maintained. So any drop in the eccentric strength of the hamstring is a major risk factor for the injury. So as I said in the final part of my presentation, when we're dealing with an older athlete who has had a history of an hamstring injury, whose eccentric strength has dropped, then I think that athlete is a high risk candidate for a relapse. So we need to address all the components. Also, we need to take into account the workload of the player when he's returned to play. Is there a fatigue component involved? Is the player recovering enough? So there are a lot of components we need to take care. But yes, I think the eccentric strength component is an extremely critical component if you're looking for prevention of relapses.
Okay. And next question is, if there is a stretching injury, when when can we do the hamstring mobility exercises?
Okay, so if it's a stretch type of an injury, I think I'll be very careful for the first 2 to 3 weeks where we don't stretch the hamstring too much. Initially, we used to do a lot of static stretching from the hamstring, but a lot of research showing nowadays that you don't stretch on hamstring statically for about 4 to 6 weeks after, at least 4 to 6 weeks after the injury. The reason being that there's a good chance that the athlete can develop a high hamstring tendinopathy at the later part of his career. So there was a good randomized control trial which was done where one group underwent a static hamstring stretching and the other group just did the rehab protocol. And what they found out was actually both the groups had a similar return to play, but the group that did static stretching in the initial phase after the injury actually went on to have a higher relapse rate. So that is a good indication for us to avoid static stretching in the initial part of the injury, whether it's a stretch or a contraction type of injury. I wouldn't be doing any static stretching for at least 4 to 6 weeks after that injury. As far as dynamic stretching is concerned, I would be a bit careful when we are dealing with the stretch type of injuries. Probably for the first 2 to 3 weeks, I would be very, very apprehensive. Whatever range the athlete is pain-free, he can definitely work on that range.
Okay. Yeah. On which angle we flex the hip?
So when we're doing the active knee extension, the hip is flexed at 90 degrees, and then we ask the athlete to extend the knee as much as they can, and then sort of record the symptoms and what range they're able to extend the knee. If the athlete is able to extend the knee for a full 90 degree, for say full extension, then we can probably ask the athlete to flex the hip, maximal hip flexion, extend the knee. That will sort of really load the posterior thigh. But again, we need to do that only if we are sure that the injury is not that severe, particularly if you're doing this in the acute phase.
Okay. What all the training we should give to athlete to prevent hamstring injury?
Yeah, I think so. We need to incorporate all the components, strength components. High speed running is one thing which we physios are generally guilty of not doing much in the rehab. We need to make sure that the athlete has done enough sessions in their training, because it's a controlled environment, before you put them into a game. The problem is if they have not done enough high-speed running in the training environment, and then they're suddenly subjected to a high-speed sprint during a game, then there's a good chance then that the hamstring will give away. So again, a lot of eccentric strength work and a lot of high-speed running in the training in a controlled environment before clearance for the athlete to go and play.
Okay, sir. So what is the healing time in grade 2 or 3?
So as I said before, I think genetic time was again probably 4 to 6 weeks for a grade 2 and anywhere around 8 weeks for a grade 3, depending on where the tear is. I mean, sometimes a grade 3, if there's a lot of retraction of the proximal muscle fibers, then the athlete undergoes surgeries and can take anywhere around 3 months for the athlete to return to sport. So, I mean, these are all generic guidelines which we read in books, but in reality, when we're dealing with hamstring injuries, there are a lot of other factors, there are a lot of variables attached before we decide on the return to play criteria.
Okay. So how many days of complete rest needed in hamstring?
I mean, again, it depends on the grade and how severe the injury is. If it's a grade 1 injury, I don't think so we need much of rest. We can get the athlete into the pool straight away. We can get them doing isometric pain-free stuff as early as possible. If it's a grade 3 injury, then obviously we need to be careful. We need to be careful with the weight-bearing status of the athlete, because obviously there's a risk of retraction of the fibers. A grade 3 injury, a grade 2 injury, probably a couple of days, sit up a lot, get them walking pain-free as early as possible in the pool, get them doing mobility work as early as possible. So that's what I said in the presentation also, the concept of RICE has changed to PRICE, and then it's changing to police now, where OL stands for optimal loading. So the earlier we start loading the athlete, the quicker they will recover, and it's good for their psychological status as well, because they feel they're doing something active and they feel they're getting stronger.
Okay. Sir, why does it take more time to heal when the injury is near the ischial tuberosity?
Yeah. So again, the issue is when the injury happens near the ischial tuberosity, the tendon primarily of the semi-membranosus. And as we discussed just a few questions back, why tendon injuries take a long time to heal, because they're devoid of blood supply, and the whole mechanism by which the tendon injuries take. So that's the reason why they say that the closer the injuries to the ischial tuberosity, the longer it takes to heal.
Okay. So next question is, how would you test when we don't have any of the quantitative measure available like Nordboard or Isokinetic machine, if you still want to strength measure between agonist versus antagonist? How do you measure the speed of an
Yeah.
athlete running other than run a 3?
Yeah. So I think that's a very good question. I faced the same issue part of my career, where we didn't sort of have any objective tools like a dynamometer or isokinetic device to sort of give us an objective measurement. So in this scenario, the best tool for us to get a sphygmomanometer, the BP cuff, try and inflate the BP cuff to 20 mmHg, and then try and use that as an objective marker. The drawback with this is that the maximum the mercury level can go up to 200 mmHg, but I think it is still a good tool for us to have if we don't have access to any equipment like the dynamometer or an isokinetic machine. I think it's tough if you don't have any objective measure, but if you want to have one for a start, I think which is inexpensive, then a sphygmomanometer is a good option to have, the BP cuff which we use.
Okay, sir. So next question is, what should be the management protocol in case of an on-field hamstring injury?
Yeah, I mean, on-field hamstring injuries happen. It's really tough for us to take a call. As I discussed in the presentation, a lot of factors need to be taken into account, whether it's the first game of the season or whether it's the last game of the season. What happens if the injury aggravates? So a lot of, and to be honest, we can't do a thorough assessment on field. We just need to quickly get a history from the athlete. Did they feel a pop sound, or are they able to walk pain-free? What's the gut feeling of the athlete? Do they think they'll be able to go through the game, or do they want to come out? So it's extremely difficult for us to take those on-field decisions because of time limitations. So the best management we can do on field is probably tape the athlete. A lot of times. What we do is we stretch the athlete. I think we should not be doing that, because in a way we are aggravating the injury if you're going to stretch it in the of the injury. So personally, I feel the best management is to offload offload the hamstrings, tape it up as and give them the athlete as much as support as we can, and then take it from there.
Okay. So next question is, by history, can we know which part of muscle is injured?
Difficult to know. So if in the history the athlete tells that he had a contraction type of injuries, then we know for a fact that there's a 90% chance that the biceps femoris is injured. If the athlete said that it's a stretch type of injury, then we know that 90% chance of the semi-membranosus is injured. Also during our subjective history, it's a good idea for us to ask the athlete where exactly their pain is, and that sort of gives us an idea where what anatomical structures we are dealing with. Yes, to certain extent we can know which muscle is involved, but if you need the findings, then I think we will need radiological assistance.
Okay. The next question is, Nordboard can be used for diagnosis purpose, or only can use for treatment purpose also?
Okay, no, Nordboard is used more for assessment purpose, wherein we sort of do 3 repetitions of the Nordic hamstring curl and get measurements. For treatment, we can obviously we have a lot of other equipments to load the hamstring eccentrically. So, sorry, ideally I will be doing a Nordboard testing once in a week if we have access to a Nordboard, and then see how the athlete is progressing with each passing week.
Okay, sir. Next question is, what should be the immediate management on field?
Immediate management, as I discussed, is it's just going to be strap the athlete as much as we can, and then try and take it from there. Tough situation when a hamstring injury happens on field in a big game, where we need to play to keep playing for in the best interest of the team. So I mean, if you ask me, the best treatment that we can offer is strapping, and I found it to be very effective in a lot of cases.
Okay. Sir, what treatment should we given if there is a lumbar involvement?
Okay, so if there's a lumbar spine proximal involvement, where there is no hamstring involvement, in the sense that when we are dealing with MRA negative hamstring injuries, these injuries will heal pretty well. So I would be doing a lot of lumbar spine mobilizations, a lot of hip mobility, a lot of neural mobilizations, like in the slump position, initially starting with sliders, and then sort of progressing to tensioners. So when you're dealing with referred hamstring pain, need to address a lot of we need to give a lot of importance to the proximal part, thoracic mobility, lumbar mobility, hip mobility. We need to make sure that whatever neural tethering is there, we need to work on it by doing a lot of neural mobilizations, and once that is getting better, I think the hamstrings will start functioning better. Generally, these injuries recover pretty well, and the athletes are on the park a lot earlier than a localized hamstring injury.
Okay, sir. Next question is, how do I know if my hamstring is pulled or tore and walking good for injury?
Okay, so a hamstring pull, a hamstring tear, they're all similar terms. How do you know if a hamstring is pulled? Is you'll feel a severe pain in the hamstring. You'll feel sometimes, if it's a grade 2 or a grade 3, you'll feel hamstring as you stretch it too much, or during a dynamic activity, or during high speed running. So the history is good for us to know if it's a hamstring pull, a tear. They're all synonymous terms. And walking good for injury depends if it is, as I mentioned in the presentation, if the athlete is able to walk pain-free within 24 hours of the injury, there's a good chance that the athlete will recover within 3 weeks. So that's a good prognostic tool for us to have on how long the athlete is able to walk pain-free after the initial injury.
Okay, sir. So our last question: for how long would you ask your athlete to do icing during the whole rehab? And if so, would ask them to do hamstring extender with icing?
Okay, so as far as icing is concerned, I think probably a 10 to 15 minute per session is a good time frame to have, because after 15 minutes the effect of icing would sort of plateau off. I would be doing this icing frequently in an acute stage in the first 48 to 72 hours. I would be doing it possibly every 2 to 3 hours once. We use the game ready machines extensively in elite sports, where there's a compression effect as well, and then you can sort of set the machine overnight, and it sort of switches on for half an hour and then switches off for the next 1 hour. You can sort of change the setting accordingly. So in the case of an acute hamstring injury, yes, icing is the most important part of the treatment, along with compression. So I would be doing it every 2 to 3 hours for about 10 to 15 minutes. And then as far as combining extender with icing is I'm a bit skeptical to start off do that. I know we sort of use icing in hematomas in a completely stretched position, especially when you're dealing with hematomas. But when we're dealing with a muscle contraction or a stretch type of injuries, I wouldn't be doing extenders immediately in the acute phase. If it's a high grade injury, yes. If it's a grade 1, yes, you can do extenders initially within the pain-free range. But if it's a grade 2 or a grade 3, then I would be careful with doing extenders immediately after the injury. Try and ice it up for a couple of days, let the inflammation settle down, and once the athlete is confident and able to walk pain-free, then I think it's a good idea to incorporate the extenders. So that's the answer.
Okay, sir. Next one is, how do you measure the speed of an athlete, especially sub-maximal to maximal speed?
Okay, I think this is subjective. This is it's extremely difficult for us to sort of get an objective measure. So what we get is during the preseason we do a 20-meter testing, we do a run of 3 testing, and then we do other testing as well. So that sort of gives us an idea on the maximal the maximum speed of the athlete. Say for example, if the athlete is able to do a run of 3 in about 9 seconds, where the athlete with the bat in hand they have to complete 3 runs in the wicket in the 22 yards. So if they're able to do in around 9 seconds, that's a good time frame to have. So post injury, when we're again deciding on the return to play criteria, we would again set the same norms for the athlete. If the athlete has done all the strength work, we are satisfied with the athlete's strength objectively, he's done enough high speed running, then we are again taking the test to declare the athlete fit. Uh, uh, we want them to be sort of meeting the criteria what they did pre-season for all the tests that we do. It could be a 20-meter sprint, it could be a 40-meter sprint, it could be a runner 3, it could be an Illinois test where we look for the agility, it could be a yo-yo, it could be a repeat. So we look for all the parameters that were done pre-season, and try and make sure that the athlete is able to sort of match the similar standards which he had set in the pre-season.
Thank you so much, sir,
No worries, Vinny. Thank you.
to patiently answer all the queries.
No worries. My pleasure is all mine. Thank you.
So I have one connection with you. Even I done my BPT from SRM College of Physiotherapy.
Yes, Rini, I'm aware of that. Yes. Thank you.
Okay, so now I over to Shauli Shutradhar for vote of thanks.
Yeah. Hello. Can you hear me?
Hello. Yes, Shali.
Yeah, Kamle. Yeah. Good evening to all who has joined us in this wonderful webinar session of IP Tripura. First of all, we would like to express our gratitude to Dr. Kamlesh Jain, who has given his valuable time and patience for sharing his knowledge with all of us. Personally, I know Dr. Kamlesh Jain as we are batchmates during our UG in SRM College of Physiotherapy in Chennai. And really, I'm honored that this time I'm meeting him like this in this platform. Thank you, Kamlesh Jain. And I personally know him because of that. He is a dynamic personality with great knowledge and simplicity. Thank you, Dr. Kamlesh, once again for giving your precious time. And it was a wonderful session, informative session. And we would like to hear you once again in future. Thank you. Now we express our gratitude to IP technical team and IPCEC members, and especially we thank our President Dr. Sanjeev Jha sir and our Treasurer Dr. Ruchi Vashne ma'am for giving us this platform. Thank you. Now I hand over to IP technical team.
Thank you,
Thank you,
sir,
Shali.
for such informative session. Thank you,
Thank you.
Dr. Birbar, Dr. Rini, Dr. Shauli, and whole Tripura team for organizing such wonderful webinars. I extended my thanks to Dr. Sanjeev Jha sir and Ruchi ma'am for providing this platform. Again, I request to all the participants, please like and subscribe IAP India YouTube channel and Facebook page. Thank you so much, sir, and thank you
Thank
whole
you.
Tripura team. Good night,
Thank you.
everyone.
Thank you. Thank you, everyone. Thank you.